Welcome everyone to this important topic in conceptual anesthesia. Today we'll be talking about percutaneous tracheostomy. So I hope now till now all of you have seen a patient with tracheostomy, and nowadays most of the tracheostomies that are being done in the intensive care unit. So as an anesthesiologist or a budding intensivist or someone looking at critically ill patients, you should be familiar with how to manage a tracheostomy, how to do a tracheostomy, this procedure. So we'll be talking about this procedure in a bit of detail and how is it different from surgical tracheostomy. And I will also tell you how over time it has become much more safer to do a percutaneous tracheostomy in the ICU. We'll be starting with the talk. So firstly, what is a tracheostomy? So creation of a stoma at the skin surface which leads into the trachea. So as you can see in the diagram, the patient's trachea is almost exteriorized to a stoma. So this stoma, and we place a tracheostomy tube in that hole. So tracheostomy tube is placed. So if you see behind the trachea is the esophagus, and in front of trachea is the subcutaneous tissue. So just see the placement of tracheostomy tube. So it started in 1921 when Chevalier Jackson standardized the technique of tracheostomy. Whereas the modern percutaneous tracheostomy that we practice in the critically ill units developed by Toy and Weinstein in 1969. So these are the two names that if you want to remember, you can remember related to tracheostomy. So most important while doing a tracheostomy is to know the anatomy. So we should be familiar with the anatomy of the larynx and the trachea. So trachea lies in the midline of the neck. So usually it lies in the midline of the neck, extending from cricoid cartilage superiorly to the tracheal bifurcation at the level of the sternal angle. At the level of sternal angle, it divides into the two main bronchus or bronchi. So it comprises of 16 to 20 C-shaped cartilaginous rings. So why it is C-shaped? Because the posterior tracheal wall is a very flimsy, soft structure. It does not have a cartilage. So the anterior structure has the cartilage, the posterior does not have the cartilage. And remember, it becomes intrathoracic at the sixth cartilaginous ring. So when it becomes intrathoracic, you can't do a tracheostomy. You have to do a tracheostomy before that. So diameter is around 15 to 20 millimeter. So what are the indications of a tracheostomy? Firstly, long-term ventilation. So I have a neurological patient in the ICU. He's unable to protect his airway. He's a patient of stroke and he requires long-term ventilation. You might do a tracheostomy. So various guidelines have suggested 2 weeks or 3 weeks. But any patient and you suspect that he will require long-term ventilation, you can do a tracheostomy early also. Then airway protection. So person is unable to cough, unable to clear out his secretions, he might eventually require a tracheostomy. Then weaning difficulty. So we have elderly patients who are unable to cough and who are unable to wean the ventilator, and we do a tracheostomy in them. And slowly over time they become better. And then some of them develop good neurological power, muscle power, good cough, and after a long physiotherapy and rehabilitation, we can actually wean them. So it helps in the patient of weaning difficulty also. Then tracheobronchial toilet, so too much upper air secretions which are not cleared by cough can also lead to a tracheostomy. Upper airway obstruction. So some patients have upper airway obstruction. The most common and critical example is the laryngeal growth. So in some people, you have to give a tracheostomy in the operation theater only. Then as a part of management of head and neck trauma. So we have patients who are referred to us and who are already tracheostomies at the primary center. That is the greatest thing about that even in tier 2 or tier 3 cities, people in the ICU are now able to do a percutaneous tracheostomy. So these are examples of upper airway obstruction which we all should know. The tumors of oropharynx, larynx and upper trachea, infections like epiglottitis, bilateral vocal cord paralysis, so patients are unable to clear out secretions, then laryngeal trauma, foreign body obstructions or subglottic or tracheal stenosis, which can even be a complication of a tracheostomy. So this is very important. How do we know the airway anatomy? So we should know the cartilaginous structures firstly. So hyoid bone, thyroid cartilage and cricoid cartilage. And then after cricoid, we have the tracheal rings. The first tracheal ring, the second, third, and fourth. And the same is shown by